care in between. Physics, art, and math got us down this path. Historical tales come alive, where science and stories dive, blending facts with heart, knowledge from the start. Me bridge blues we sing to the future memory. Health and science in the mix. Me bridge got the fix. Complex subjects make
right
clear
now
every episode
in ways that we actually acquire
leads the way,
and ways that make me more efficient.
in the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges.
Hey, welcome to the MedBix Webcast. This is Raman Namaraju. I'm the host of the MedBix. You know, we have a very interesting guest today. I tell you that, an international global management executive. You know, actually, I've been in healthcare for a long time, beginning of the stages of this healthcare evolution. You know, I used to live in Atlanta, Georgia. In the South, I placed a lot of, I was helping the medical diagnostics, and then ran an imaging center and placing doctors, J1 visa doctors in the rural areas and urban centers. And so I did all those things. One thing I learned is that, about the first time I heard about Kaiser, actually I went there to do some research. What is this Kaiser Permanente is talking about? There's an Indian doctor, as a OBGYN doctor, joined the first time in Atlanta. I heard about him. I said that, what is this? Oh, we are a small outfit and we are joining in the Kaiser Permanente OBGYN doctor, he said. Okay, very good. And he's very happy, that they're giving all these things. I don't have a headache. They're managing everything for me. And then I want to know a little bit more about it. And I went there and did some research. I found out very interesting. Henry Kaiser is the very entrepreneur, is a different out-of-the-box thinker. And then Dr. Sidney Garfield, these together in 1930s, believe me or not, in 1930s, what they did was in the Columbia River. I mean, there is a grand river in the Columbia Basin in Washington State, I think. They did all the irrigation workers, all the dam laborers and all those people. They are managing their healthcare, prepaid healthcare system. They started in 1930s. They extended to World War II. Then it became Kaiser Permanente, and is a huge success. Their staff model is usually, they started as a staff model. Eventually, they evolved into the big health plan, and evolved into the global. Now they are very highly successful. We want to find out what that is from a senior executive from Kaiser Permanente. Actually, let him explain all the little bit of confusion of all these groups that Kaiser Permanente has. So, executive from the Kaiser Permanente, Lawrence Hamilton, he's born in London, he said. Then he moved to the United States. He spent a lot of time in England, and then NHS system. NHS. Everybody, we always in the political times, in the election times, always NHS comes in the picture, whether we like it or not. So NHS, so he understood that NHS system, and then he came to the United States. He is a Kaiser Permanente top executive there. Let me bring him to the table. Let him explain his background a little bit more. Welcome, sir. Welcome, Mr. Hamilton. Welcome.
Thank you so much, Ramona. It's delightful to join you. I appreciate the invitation. It's great to join the MedBricks audience today.
Thank you, sir. So tell us a little bit of your journey from London to Oakland, if you don't mind.
Yeah. So as you said, born and bred in Britain, and went to college there. And as I was finishing college, I studied politics, philosophy, and economics in Oxford. And I knew that I wanted to do something that contributed to society. And this sounds cheesy, but it's true. It was late at night. Everything was dark apart from one building on top of the hill. That building had all of its lights on. It was the hospital. And my epiphany was that building is full of people in the community who are at their most vulnerable. And the building's also full of people whose vocation in life is to look after people when they're at their most vulnerable. That seemed to me like a wonderful microcosm of a good society, a healthy society. So it led me to explore joining the National Health Service, the NHS Administrative Fellowship Program. And I wasn't sure, to be honest, whether healthcare and healthcare leadership was going to be what I wanted to do forever. But what I learned very quickly is doing work which is all about helping the community. So, we know that healthcare is just so intrinsically important to our communities, the people we live amongst. Doing that alongside people whose vocation in life is to help others, that feeds your heart, feeds my heart all the time. In combination with it's complex, as you and I were chatting about earlier. Health policy keeps changing, technology keeps changing, science keeps changing, expectations keep changing. And so intellectually, it's fascinating. So it feeds your heart and it feeds your head. So that sense of purpose of doing something that feels valuable amongst colleagues who share a same passion. So that's why I came into healthcare. And then I worked in the NHS for about 10 years, both as a consultant and as a leader. And then I had an opportunity to go to Tanzania in East Africa, chief executive of the Aga Khan Health Service in Tanzania, where I worked for 5 years, and really opened my mind to the global health systems, and also as a family, what it meant to think of the world globally. And then I asked myself a question: which health system came closest to what I'd create if I had a blank sheet of paper? And at that time, Kaiser Permanente's work, I think internationally renowned for population management, chronic disease management. It was also at that time, excuse me, deploying an electronic health record. That was not unique in 2004. Other leading health systems were doing the same, but other leading health systems, they were deploying an electronic health record that enabled hospital departments to talk to one another.
Yeah.
Kaiser Permanente was doing that, but on top of that, they were enabling patients to email a doctor. They were enabling patients to see their own medical record. They had full integration of primary care to specialty care and hospital care. That felt like a generation ahead of anything else I'd seen. So that led me to apply, and then I was lucky enough to get a position in 2005. So I moved from Tanzania to California. And I've done now 5 jobs with Kaiser Permanente, some of them in Northern California, some in Mid-Atlantic, in the DC area, some with the health plans, mostly with the medical group. And I'm now privileged to be exec vice president for the medical group in Northern California. We look after 1 in 70 people in America. So that feels like an enormous privilege. And we have 55,000 colleagues, and patients that we care for have a 30% less chance of dying from heart disease. They have a 20% less chance of dying from cancer. And we do it at a cost that is significantly lower than other health plans. So that still feels, in terms of what brings people into healthcare, that ability to impact population health at scale seems utterly compelling to me.
Can you quick rundown on the Kaiser Permanente's structure? The relationship between the health plan and Permanente Group. Just a little bit rundown on the people. A lot of people gets confused about this, the different things. Yeah.
Yeah. So structurally, there, exactly as you said, there is a health plan and a hospital system and the medical group. The thing I'd say that makes it unique is really the integration between care and coverage. And I think the best way to describe it, if I may, is through a patient story. A few years ago, we had a woman who I'll call Mary to protect her privacy in terms of HIPAA, but she had a lump on her neck and she had 3 children. She was a single working mum, so really busy and hadn't managed to get to a physician. but her sister was staying, and she said, I can look after the kids. Why don't you go and get it checked out? Because it's clearly worrying you. And she phoned our contact center and got an appointment to see her primary care physician later that day. She saw her primary care physician, who said, I think we should have a dermatology appointment. And so they called the roving dermatologist, who came to the office, examined her, and said, from a dermatology point of view, I think it's okay, but I recommend that you see a head and neck surgeon. They called the head and neck surgeon on the phone, and the head and neck surgeon said, I'm happy to see Mary, but for me to make a definitive diagnosis, she should really have a CT scan. So a couple of hours later, she had the CT scan. It was read by the head and neck surgeon, who saw something she was worried about and called a thoracic surgeon at our neighboring hospital, because we don't deliver thoracic surgery everywhere. And together, the head and neck surgeon and the thoracic surgeon got back together with Mary and the primary care physician and said, what we recommend is that you come in tomorrow, you have an interventional radiology procedure that will take a sample, it'll go to histopathology, we'll read the sample, and then we'll decide the next plan. And we'll have a surgical team if we need to operate, so we can do it there and then. That all happened, and unfortunately, the histopathology revealed a fast-developing, fairly unusual cancer. They met with the oncologist, and they went back to Mary and said, we recommend actually a course of complex chemotherapy, and she started on that the day after. The reason I tell that story is because if you compare what would have happened to Mary compared to if she'd been in the world outside, each of those stages would have, with a physician, the recommendation would probably have required prior authorization. So it would have gone off to a health plan. It would have taken 48 hours, 72 hours, however long, to come back with an agreement or not to whether to go to the next stage of care. So that fragmentation that we have in most of the US of the health plan over here and the physician over here versus the patient making a decision with their physician. In the Kaiser Permanente system, the health plan is wrapped around the care delivery system, and so there isn't really a process for Kaiser Permanente physicians to go through a prior authorization process. We know in the world outside, the health plan tries to coordinate all of these fragmented medical offices, these hospitals. Often they have financial incentives to try and maximize their revenues. We don't. We see our hospitals as a cost center rather than a profit center. And so there isn't a competition between hospitals. So if a patient needs to move to a hospital because they have a range of services, there's no barriers to that happening. When we need to bring together a thoracic surgeon, a head and neck surgeon, and a dermatologist around the patient, there are no barriers to that. Nobody's competing for patients. Nobody's competing for income. Nobody's trying to generate RVUs. So I think, in my mind, that helps explain better how the integration really creates value at the patient level. Of course, we've got the organizations behind it in terms of board structures, etc. But really, the heart of it is how do you bring value-based care to the individual patient with as few barriers and friction points as possible for that patient. That's what delivers better outcomes for the patients, better care experience, expedites care. Does that make sense?
It makes a lot of sense because, if you see that, all the other systems sometimes is so frustrating, what you saw in the incident in New York City with that, the frustration, any violence is wrong, nobody is condoning. The problem is that frustration is there among the public. US public, American public is frustrated because they don't know where to go, what to do with the healthcare system. It's becoming complex system. So that's I think Kaiser's one of the successes that the coordinating this care and also your incentive is the biggest incentive is prevention is probably your central goal of the whole system. Explain a little bit about your goals of the system and how your prevention plays a role in the Kaiser system.
Yeah, no, that's exactly right. That because we are prepaid, instead of trying to each player trying to maximize their revenues, really our joint collective incentive is how can we do the best possible job with the dollar that the patient gives us to pay for their care.
If you want to get a glass of water, please go and get it.
Thank you.
Yeah.
Thank you.
Please don't mind.
Mm. So it really leads to just a very different set of questions, a different problem that we're trying to solve. And for us, everybody's aligned around how do we produce the best possible population level health, the best individual outcomes for each patient, and do so at the cost that's most affordable to the communities that we serve. Unfortunately, I think that's dramatically different from most of the questions that people in the US health system ask are just different. And it's not that the individuals themselves have bad intent. It's that the system is structured such that the things they are incented to do, the problems they're trying to solve, are not aligned with what health systems need to do to produce population health. And you'll know the data that when the US spends way, way, way more than any other developed economy on healthcare, and the outcomes that we get, unfortunately, lag pretty much every other advanced economy.
We used to have a joke. The joke is that, we build a big casino and tell the doctors not to play, they don't play gambling, So it's a huge casino in front of you. And that is a system that we have. Unfortunately, that is a huge casino there, and then not to play. It is a system that is, you see, the United Healthcare CEO said that nobody with the right mind decide, do this kind of design this kind of a healthcare system. That is the one thing Kaiser really did very well and slowly organically progressed very well. You took that structure, and prevention is make it a central process. And then innovation, definitely innovation is at the center. You are not averse to the technology or not averse to the innovation. So tell us a little bit about the Kaiser's innovation ideas a little bit.
Yeah, I think it all goes back to how do we support our clinical teams, our physicians and clinical teams, to enable them to do their best work and to provide the best possible care that's aligned with the evidence and produces great population health outcomes. So I'll give you an example that's not a new one. It's fairly established. We call it I Saved a Life.
What is it called?
I saved a life.
Okay.
If you're in the emergency room, it's really clear when you save a life. When you're doing preventive care, it's much less clear. I remember watching an adult and family medicine doctor talking to his medical assistant, and he said, "Your job description has all your tasks, but what I want you to know, at the heart of our job is we look after 2,000 patients, and if we do our job well, then nobody dies of an avoidable disease." So, to give an illustration of that in practice, we have a thing called, as I mentioned, I Saved a Life, where if you go and see any physician or clinician, we have systems that pop up and say, Mr. Hamilton is overdue for his FIT test for colorectal cancer screening. So if you're seeing a podiatrist or you're seeing an optometrist or you're going to the pharmacy, everybody gets that pop-up. So that's one of the reasons that we get good outcomes, that we're about 10 percentage points higher than the rest of the nation in terms of screening for cancers. Then, if it turns out that I then go and get my FIT kit done, and it turns out, unfortunately, I've got cancer, on the back end, we look at the systems and we find out who it was that convinced me to get the test done, so that we can go back and celebrate and recognize those individuals with an I Saved a Life award.
Oh, really?
So you can imagine, although that sounds sort of simple, you can imagine the systems in the background to track and make it easy at the point of care to see what I need next. And then the systems on the back end to track back and find out who it was that provided that care, so that we can recognize them, we can role model them, we can celebrate them, so that their peers also want to deliver care in the same way.
That's a beautiful. You made a post on the cancer screenings, how that quickly, it's very interesting. I was reading that post, that you made it about the cancer screening and Kaiser structure, how the doctors move that so fast. And really that you illustrated very well. That is the central theme of, one time I was working for a HMO. I was helping somebody, HMO in Georgia. Then they told me, can you manage a lot of doctors? They ask me, how do you manage doctors? It's very complex, and they're a little bit of a headache. How do you manage all these doctors? I said that, how do you define who is a good and who is bad? I said that, I thought about it quite a bit, and then said that, as you exactly said, that who refers first, and most of the referral process, how that works. If 10 patients are referred, is a 0 positive there, is not a is not a great doctor there. Or if there is a positive things there, and we appreciate that doctor and how much that he saved life. We didn't do that part, but exactly, that is a process very appreciated. Actually, that is a once you distinguish that difference, you can recognize the doctors, and they feel they recognize it. They are not some undertone somewhere. That's a very, very, I save life is a beautiful concept.
Yeah, and I will say it applies not only to our physicians, but to all of our staff. So
Yeah,
receptionists
no,
would
yeah,
go in as well as
absolutely.
physician. And then I think you make a really good point that I think our patients and the public too often feel exasperated by the US health system, how many barriers there are, how many friction points.
Yeah.
I think is exactly the same for so many health professionals. When you read the reasons for burnout, it's so often because our health professional colleagues have done years and years of training. They are highly motivated to provide the best possible care. And unfortunately, they feel too often in our system, they're unable to provide the care they want to provide, whether it's prior authorization or other barriers to delivering great care. In our system, our physicians are both have an ownership mentality and are actual owners of the medical group. And so we believe that when physicians are at the center of creating care systems and care delivery, and we harness that sense of ownership and we give agency to create a system, that you sometimes give up your individual autonomy to create a system that overall collectively delivers better results. That's the best formula for attracting, retaining, and inspiring the best health professionals, because they get to do the work that they train to do every day. I can't tell you the number of times I've had interactions with physicians and clinicians who said when they've worked elsewhere, they felt like they were always working against the system to do what they needed to do to deliver their best care. And when they join us, when we're at our best, they're supported in delivering the care that they believe is the best care for their patients. And I hear the same from patients too. When they've when they've been part of other systems, they felt that they've constantly had to fight against the system, or they've spent their whole time sort of navigating how to get the care they need. And when they join us, they feel that we wrap around them and give integrated care so that they can see their physician at ease, have their labs, their RAD, their pharmacy, all in one visit, that we're doing the preventive care that they need in addition to any issues they have. That when they need complex care, you haven't got people fragmented and discoordinated, but it's integrated and focused around the patient. So to your point, I think it's we know that there's really a crisis of burnout. I think about 50% of health professionals have symptoms of burnout. And we know with the aging demographic, there just are not enough health professionals joining compared to the number retiring. And so a challenge, I think, is to make sure that we're creating the environment where the best health professionals get to do their best work.
One of the things you took it out big, but I used to visit the doctors for work. And when I was waiting in the waiting room, I used to hear the screams from the back rooms from their insurance, fighting with insurance companies. It is a huge, that everybody can be so uncomfortable. It is unfortunate. It's not just one office. I've seen everywhere I go with the independent practices. That is a big challenge, and that you took it away. That biggest headache for the doctors, you took it away from that one. They want to provide care. They want to help patients. I think that is, you made it a central theme of that your group, and the Kaiser Permanente's motivation was that to make it the central theme.
I think that's absolutely right. And then you talked about innovation. So partly it's our integration sets us up for success. the focus on population and individual health is critical. And then, clearly technology presents all sorts of opportunities. I'm a big proponent. It's easy to blame electronic health records for the amount of documentation, but I don't think we should romanticize what life was like before electronic health records, when we didn't have best practice alerts, when we didn't have order sets that where we relied on people's memories about what labs to order, et cetera, et cetera. And we know at the same time, it's another cause of burnout when people feel they're spending, that essentially the computer is coming between them and the patient. So I think you'll be aware that I think it's the world's largest rollout of ambient listening technology. So we've now got it available to 25,000 physicians. On average, it saves 1 hour per day of pajama time. At the most extreme, it's saving 3 hours per day. And so partly it's the saving of time, but also it's the sort of quality of experience, both for the patient and for the physician, where instead of feeling like you've got the computer between you, you've got the computer over to the side, capturing the relevant information, and the patient and the physician are able to talk directly. So that's another example. And I think continuing, clearly AI and augmented intelligence is going to continue to present. It's although it's imperfect now, it's moving at such a pace that it's going to present opportunities that will help if we apply it the right way.
Let's talk about in a minute about the AI, but let's talk about your role in the Permanente group. You recruit doctors, you give a contracts, you have a different, you negotiate contracts with each doctor and all those things. That is overall, that is the Permanente group is recruiting doctors, managing them, and administering their benefits and everything. That is one of the biggest challenges, probably. That's what you do in the Permanente group.
Yeah, we have 10,000 physicians and 45,000 staff within the Permanente group. In KP as a whole, it's about 25,000 physicians and about 260,000 staff. So yeah, we employ a lot of physicians. When they become senior physicians with us, they become owners.
Really?
And so they are completely absolutely central to the design of everything we do. And then we try to create that same ownership mentality for all of our colleagues, because it's I think so fundamental to delivering best outcomes for our patients.
I work with the AI company. Let us talk about AI, artificial intelligence. I saw your notes. I agree. One of the things is there is a lot of noise and there is a lot of reality there. Before pandemic, I want to be a little critical about the AI, a little bit at least. I'm a technology guy. I live in Silicon Valley. I have a physics degree, and I did a lot of technology. But I tell you what, before the pandemic, they were claiming that we can predict everything, including the flu season, everything they claimed a big way. But there was a storm, which is the pandemic, they could not recognize, and the 8 million people died. That was my criticism. So, at the end of the day, the doctors and the people in healthcare systems have saved the money, saved the lives. Not this there is a mistrust of artificial intelligence and technology by the doctors, understandably so. So tell us a little bit about your experience and what do you think? You mentioned Dr. Eric Topol. I am a great fan of him. So tell us, there is a reality there. There's a lot of noise there. How do you distinguish in the healthcare system from your point of view?
Yeah, no, I think you've put it really well. I think it links to some of my comments earlier that when we use the potential of predictive analytics, advanced analytics generally, that we have physicians absolutely central to the design and the deployment. We've got the benefit of health data that goes back to the 1970s, right at the inception of computerizing electronic health records, when it's literally kind of punch cards to collect data. So we've got a database which is defined clinically rather than by billing, that it's longitudinal, and it has a very diverse population. We think that's a huge
database
asset in terms of building large language models that we can test. And so we've used it. I'll give a couple of examples. We have a thing called Advanced Alert Monitor.
Advanced what?
Every, it's called Advanced Alert Monitor is what we call it. It basically tracks every inpatient and emergency room patient and flags if there's a predictive likelihood that they could deteriorate very quickly in the next 48 hours.
Something like sepsis kind of thing?
Yeah. It tracks about 240 markers.
Okay.
What we learned was if we automatically alert the team every time the system fires, then there's enough false alerts that it frustrates the team. So actually, when it flags, it then gets interpreted by a human who makes the final call about whether to call the team, and then the team comes together. Our research shows that we're saving about 500 lives a year using that predictive analytic. But to your point, it shows how if it's crassly deployed without testing, without validation, making sure that it's not only the technology, but it's the integration of the technology with the team and the different workflows that are taken as a result, and then the follow-up to robustly research what the outcome has been. If you put all those steps in place, then it's incredibly powerful. Yes. But if you just come in with a simplistic approach, then often you get the results are not what you expect.
One of the under-recognized thing is your research. Kaiser has a very tremendous research. I was surprised by, that how much that they have the data. It is actually can feed the large language model itself. You have that much data, 1970, you're saying that. So think that you can produce the research that people don't know about, that how much Kaiser can, the clinical research side, how much you contribute. My son works in the clinical research side. So I think it is a tremendous value. The data from the Kaiser Permanente itself, that's one thing. Thank you for bringing it up. Of what is the most under-recognized thing in the Kaiser world. We don't know. Public doesn't know how much that they contribute into the clinical research side. Impressive, very impressive.
That's work for us to do. I think we're doing a better job at sharing, but there's still opportunity, as you say. Yeah. I think we're the biggest healthcare research outside of large universities and the VA. And it's definitely powerful internally in terms of continuing to refine and improve what we do. And but we also want to contribute to the research evidence for the world at large.
So one of the things, every time I go outside, one thing I hear from doctors is, yeah, he's going to replace me. That's one fear they have, So NVIDIA came up with the nurse bot, and healthcare system, health of a human biology is a complex system. There is no system is that enough. Artificial intelligence is still artificial. It is not reached the complexity of the human biology. I don't know how I can replace the doctors. So tell us a little bit about that. This fear the doctors express all the times that they're replacing the AI is going to replace it.
No, we're really clear about talking about augmented intelligence rather than artificial, because we think the power is the power. A physician alone is clearly, I think it's very clear, is less good than a physician augmented by intelligence.
Yeah.
I don't worry at all about this. My worry is the opposite. That I think all the indicators are that we won't have enough health professionals. Yeah. We don't today, particularly in primary care, but also in multiple other specialties and multiple other disciplines. So for me, it's a race to find augmented intelligence that's good enough to mean that we can continue to deliver the care that people need when we know that the workforce is much smaller than it used to be. This isn't just a US problem, it's a global problem. Yeah. All of the forecasts suggest, just given the demographic changes that we're seeing internationally as well as in the US, there's not nearly enough people to deliver care in the way that we've been used to delivering care. So the faster we can find ways of augmenting the fewer health professionals we'll have with really high quality artificial intelligence. That's really the path to delivering better care. And I know you've had other guests. Robbie Pearl's, I think, a superb advocate for a potential future where we enhance what we do in terms of patient care, because we can provide 24/7 patient care rather than care dependent on an appointment.
Yes.
And support clinical teams, physicians with clinical teams, to deliver far better care than we've been able to in the past, informed by leveraging technology and then using AI to amass data and use it for predictive, use it to help professionals. I'll give you a quick example. We've got a program where we track our most vulnerable patients who aren't in hospital, and we surround them with a team. Originally, that team could only look after 300 patients because they're our most vulnerable. They're very intense patients. Then we started to use advanced analytics to work out which, not just refer the patient to the team, but to refer the patient to the specific member of the team whose help would help most. And then the moment they return to baseline, to take them out of that person's work queue and put them into a monitoring pool. That work enabled us that team could care for 5 times more patients than they could do originally.
5 times.
So I think it's a great example of how this isn't about replacing people. We'd never have enough people to care. With the demographic changes, as people hit 65, that's not a problem. But as all those people like you and I hit 80, 85, 90, we know that our utilization is likely to go up. So we've just got this large demand supply gap growing internationally and in the US.
Yeah.
And the only way we're going to meet that gap is by finding ways to use technology well and equipping our health professionals with the ability to use that technology so that we can care for more patients.
Dr. Gary Goldman says that is assisted intelligence, not AI. He calls it assisted intelligence. That's a better word. I agree with that, with your analysis on that same thing. So it's assisted intelligence and augmented reality. That's what the intelligence it is. One of the biggest challenges for you, as you said, that is a humongous. We are aging. A lot of people are living longer. 1950s and 40s, people used to die at the age of 60. Now we are living 70s and 80s and 90s, and then this is a huge demand on the workforce, healthcare workforce. How do you foresee this kind of a demand? How do you want to? You're a global executive. How do you want to do? Resource allocations. It's a biggest challenge that you're facing in the world. Tell us a little bit about that. What kind of things you're planning to, how you're thinking about it.
Yeah. So I think just to round out the picture, given all of the different things we could focus on, the top 3 that we are focused on is one around how do we make sure we can attract and inspire the best health professionals because we provide an environment where they can do the best work. So that's number 1. Number 2 is with an aging population, how do we transform care so that we're ready to care for that population as it grows as dramatically as it will grow? And that covers many things. We know that at the moment, care coordination, when people have multiple chronic diseases and are reaching the most fragile time in their lives, access to care, transport to care, providing appropriate services in a home environment rather than in a hospital environment, will require health systems to really transform what they do today, and also understanding what patients value and making sure that our care is concordant with what patients value. We know that most patients want to be at home, and unfortunately at the moment we end up with far too many patients being in a sort of revolving door between intensive care, between the hospital, backwards and forwards, in a way that doesn't reflect how they want to spend their last days. So that senior population is the second, and then the third is the younger generation. When you look at the data suggests that the younger generation has much less confidence in the health system in meeting their needs. it's still, when you look at trust across different groups, healthcare is still doctors and nurses are the most trusted health professionals, the most trusted professionals, and yet the level of trust has diminished over time. And their trust in health systems and trust in health plans is at record low levels. So how do we make sure we're responding to their needs? So making sure care is available digitally as well as in person. Making sure the whole system is all based on preventive care and keeping people healthy and being people's partner in health rather than just in sickness. That motivates a lot of the work that we're doing to prepare for the future.
Just can you give me a couple of minutes about the chronic conditions, the chronic care? What do you do with the chronic care? Most of the people don't have either diabetes, hypertension. These are all these prevention is after the prevention. Sometimes we are humans, we get these diseases. How do you manage that in the whole process? How do you allocate resources for that?
Yeah, so as you say, we put a lot of resources into trying to prevent. And then it's exactly as you say, not everybody is going to be perfectly healthy forever. Yeah. And so we look across the whole span of care. If we take cardiac span of care, we're identifying subpopulations and making sure that they have the support of not only their primary care physician, but also health educators, nutrition, increasingly services outside of traditional healthcare. That might be to do with food or housing or financial support or housing support. So that holistic view of a person. And then you go all the way through to specialty care. And because we in Northern California look after 4.6 million people, and we're all focused on population health, we have 3 major centers that offer cardiac surgery. So we can do it at very high volume. And we know high volume tends to deliver much better quality, much better efficiency, much better care experience. So when we look at the Bay Area, we have 2 centers serving the Bay Area. There are more than 12 other centers in the non-Kaiser Permanente world, many of them very small volume. The sort of headline is that our volumes of our 2 centers are double the most reputable academic medical centers in the Bay Area, and our risk-adjusted mortality tends to be about half. So I illustrate that to say that when we look across the continuum of care and where to allocate resources, whereas in the world outside, because reimbursement is so much higher for specialty care, for tertiary care, for complex care, that's where people tend to invest all of their money and energy. For us, we ask a different question. We say, how much can we put in prevention? And then when people get seriously sick, what is the most cost-effective way of delivering the best possible care? And so we end up with centers of excellence that we can refer high volumes of patients to. What the specialists love about it is that they're not having to compete for referrals and see lots of patients that they don't really need to see. They get to do the work that they are uniquely skilled and expertise to do. And we can kind of deliver, because of our system, we can deliver them high volumes of referrals. So they get the satisfaction of doing the work they train to do. They produce better quality because they're spending all of their time doing that work at their expertise edge. So I hope that helps explain how we think about the way we distribute resources across the whole system. We can think as a system rather than each piece being fragmented and in competition with the other pieces.
Nice, very, very nice. But I wanted to ask you that resource allocations you just mentioned, not just physicians. I don't want to undermine the nurses, the technicians, for the CT scan technicians. There's a huge demand for them, radiology techs and cardiology techs. How do you, all these people is an integrated system, right? Is really providing integrated care. How do the resources, how do you allocate? It's the biggest challenge for the management point of view. Is one of the biggest challenge for you. How do the successfully the Kaiser is doing very well. How do you do that? And what is the model for that actually to recruit not only technicians? We have a lot of people. The biggest challenge is not only doctors are there. I understand there is a lot of shortage, but technicians also a big problem now. Nurses and technicians. How do you solve that problems in general?
No, absolutely. My comment around preparing for shortages, absolutely. We've got the problem is at least as acute in other health professions like rad techs, like laboratory staff, like nursing, as it is for physicians. And so we need to be mindful of both. Our overall pattern is to start with the question of what's the most cost-effective way of dealing with of caring for the whole population. Whenever we can solve a problem upstream and solve it well, we call it point of care resolution. You can tell I'm recovering from a cough. On Friday, I called, instead of making an appointment, I did an e-visit where you can go through a series of questions. The e-visit, because of the way I answered the questions, in this case asked me to get in touch with a nurse who I could get in touch with. They ordered a prescription that was available for me to pick up in a pharmacy 1 hour later.
Very interesting.
If you think, I realize that's just one example, but we do that across the health system for all of the most common conditions. So rather than, I think in many health systems, you staff based on RVUs and productivity models. Our staffing is based on how do we solve the problem for the patient first? And then when we've worked out, we do a lot of demand modeling about how many patients do we need to see by hour of day, by day of week, in primary care, in pediatrics, in specialty care. And then we make sure we staff to that need. And so we have a combination of how can we go upstream to make sure that we're delivering the care most effectively? And then for the care that we are providing, what's the most productive way we can provide that care? So what's the balance between physicians and physician assistants, or the balance between rad techs and MRI techs and CT techs? So we do a lot of work to continuously refine that, and there's always new opportunities. And then we work on the back end. We have a School of Allied Health where we're training rad techs and phlebotomists. It's a fully established university status organization, so that we're increasing the pipeline of people that we know that we'll need.
Is it located in Los Angeles area?
So we have a medical school in Los Angeles.
Medical school. I met your president last week. I went to a conference. Then I met the in charge of that gentleman. I was surprised that Kaiser has a medical school.
Yeah,
I didn't know that.
So we have a medical school there, and then in Richmond, in Northern California, is where our School of Allied Health is.
Oh, really?
Where we're training other professionals and mental health professionals, medical assistants, rad techs, phlebotomists. So we have that combination, and then we have a really substantial number. Those are the kind of 2 university departments, and then most of our departments do teaching in one form or another of students who are rotating, doing clinical placements, so that we can create a pipeline for whether they choose to work for us or they work for other employers. Hopefully they work for us.
The TPMG is under the TPMG, or a different, the school system is a TPMG?
Yeah. The school is part of our system. And then the clinical placements, we tend to do that in partnership with a whole range of universities.
I attended a president's breakfast in the Charles Drew Medical School. I met the president of your school up there. Mr. Hamilton, you wear a different hat. That's a teaching professor. You go to the England and teach that. What I wanted to ask you other way around, what is the British system, NHS, National Health System, can learn from the Kaiser Permanente?
Yeah, that's a great question. So just for your guess, I'm honorary professor of practice at the Global Business School for Health at University College London. It's the first business school that's both international but focused solely on health. It's been in existence for about 3 or 4 years. And it's a real privilege to join them, partly because I'm passionate about how we can both teach and learn from the next generation of healthcare leaders. I think it's physician and administrative and financial leadership is absolutely crucial to creating health systems that deliver great outcomes for our patients and our communities and the people that work in them. So it's a privilege to be able to contribute to that. To your question about what can the NHS learn from
the Kaiser Permanente.
obviously there's learning both ways.
Yes.
When I'm in the UK, the things that are clearly what the NHS has struggled with in the last few years is the a higher and higher percentage of the healthcare budget going to hospital care. So you've probably read they're in the middle of developing a new 10-year plan for the NHS. And there are 3 themes: to move from hospital to community, to move from sickness to prevention, and to move from analog to digital.
Prevention is a central part of it.
Completely resonates with a Kaiser Permanente and TPMG perspective.
Yes.
It's exactly what we do every day.
Yes.
When I was there recently, the NHS has approximately 3 acute beds per 1,000 population. That compares to approximately 1.7 beds per 1,000 population for Kaiser Permanente Northern California. So that gives you, the hospital is the most expensive part of the delivery system. If the NHS could find a way to only need 1.7 beds per 1,000 population, that would free up enormous resources to spend on prevention, on digital, on care in the community. So when I was there most recently, that was the audience was most inspired, excited, intrigued by what could we learn from one another that would make the healthcare system less reliant on hospital beds and be able to distribute budget to the preventive part of the health system.
This is a global need, right? That the prevention is we need to shift from the sick care to the prevention side of it. The preventive care is a very important. This is a trend is actually, my father is a doctor and a teacher in a small town. He's like you, he was teaching high school and he is also a small time rural doctor. And he was wearing both hats. And then it is really challenge. Prevention was his game at the time. Food as a medicine in Ayurveda, in Indian system, we were taught the day one. British people were there all the time. So my father was under the British rule. So that we left that field and then we went to sick care. Somewhere incentivizing that process was the biggest mistake I think the world made. I think the wrong direction. We are learning from it. We had to learn from it. So we think this is going to be this new kind of a paradigm shift into the preventive care is going to be Kaiser Permanente's gold standard, is going to spread across the world. That is. Do you agree with that one? That is a most important.
I absolutely hope that's where we go.
Yeah.
I don't know how confident I am. I first came to the US in 1990, and at that point, the US was spending about 11% of GDP on healthcare, and everybody was saying, it's absolutely impossible that we could possibly be spending 12, 13, 14% of GDP. How could society possibly afford it? We need to change.
Yeah.
As you know, we're now approaching 20% of GDP. It's the same sort of conversation. How could we possibly... And so I'm a little humble about whether we'll be successful, but I absolutely 100% agree with you. Don't get me wrong. Some of the interventions that we're able to do now that we weren't able to do 40, 50 years ago are extraordinary. They're life-saving. So it's not an either or. We need to provide, the things we can do now in terms of things like cardiac surgery, neurosurgery, cancer care are remarkable. But if that's our sole focus, then we know that's not nearly enough. And so the work that we do, and we still have more work to do. How do we continue to go upstream, continue to make sure that we fully integrate physical health with mental health, with social health, that we create communities that are where we give people easy access to the food, housing, financial, as well as healthcare security. We've got to be part of that journey. Are we better positioned than most? Yes, we are. Do we have a great track record? Yes. And that's where we see our future, is continuing to push so that when people are sick, they get great care, and we're their partner in helping them to lead healthy lives for as long as possible.
There are beyond sometimes healthcare system is societal problems, systemic problems in society, which is gun violence and food processing. The food is itself. So a lot of other problems in there that we need to solve all together. Healthcare system is a Kaiser Permanente is doing extremely well. I'm fortunate enough to meet some doctors, and they always gave a good compliments about it. And I was surprised how happy they were, and that is a surprise to me. That's something that I need to learn. That's what I thought, from them and all these. I think you're doing a great job. I wanted to, that epiphany moment you mentioned. Lights are on 24 hours. That's a beautiful story you could tell. That is my father. I was a small village in India, rural village in India. I was born in, and my father was delivering a care for the people who don't have electricity, we don't have a running water. And then my father is getting up in the 2 o'clock in the morning and going to the sick patients. That is a 24 hours a day job. And it is nothing but if you witness that, is a total inspiration. You are blessed to that blessing. You had that tremendous blessing, and you are educating the next generation of people. And thank you. It is so much, it's truly an honor and privilege to have you on this podcast, Mr. Hamilton. Really, I learned so much from you. Thank you so much. So if you give me I give you a last word. Anything
I very much appreciate that. Like you, I feel an enormous privilege to be able to do work that feels very purpose driven, benefits society, and do it surrounded by colleagues who feel similarly inspired. I love what you do of bringing an incredibly diverse range of voices. As we said, healthcare is intrinsically critical to a healthy society, and it's a complex problem. And so it benefits from having just a very diverse range of expertise and perspectives to try and help one another find better systems that will keep our communities healthy. So thank you for the work that you do in creating a public square for us to have these sorts of conversations.
Thank you, sir. Thank you for coming from you. It's a very great honor for me. Thank you, sir. Good night, all of you. Thank you all for attending. Good night, all of you guys. That's thank you. Wonderful, wonderful thing. Good night.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.